Thank you so much for the introduction, and thanks so much for the invitation to be here. I really appreciate it. So I'm going to talk about, as the introduction already said, I'm going to talk a little bit about hepatitis C elimination in Canada and in the United States and do a little comparing and contrasting. I don't have any disclosures. So just as a way of introduction, this all came from around 2016, where the World Health Assembly invited member countries to try to eliminate hepatitis C by 2030. And each member country was asked to kind of look at 5 different strategic directions in order to make their own elimination strategies. The first strategic direction was focused on information. So who and where are the people that we're trying to reach? The second one was, what are we going to do? What are going to be our interventions for impact? The third is, how are we going to do it? How are we going to pay for it was the fourth. And finally, what type of research will be needed? So as everybody in this room probably already knows, there's about 250,000 cases of hepatitis C throughout Canada, and it sort of varies depending on where you are in the country. For those of you that were here a little bit earlier, Jordan was selling the blueprint pretty hard. I don't know if I'm going to sell it better than he did, okay? So I won't promise that. I don't have copies with me, but I did use a copy that's available online, and it's very easy to navigate. And it was really interesting for me because, as was mentioned before, I was part of the US elimination strategy. So this was really, from a personal perspective, really great to see how these two elimination strategies compare and contrast. So by means of a timeline, this really started in 2018 with a commitment, and then working groups were formed, development webinars, stakeholder workshops, drafting phases in 2018 and 2019, and finally the release in April of 2019. And the blueprint really is quite comprehensive, and it deals with really everything from beginning to end of what needs to happen for hepatitis C to be eliminated within this country. Talks about stigma a lot, talks a lot about priority populations. We're going to spend a lot of time talking about that over the next couple of minutes. Federal recommendations, monitoring progress, prevention of hep C, testing and diagnosis of hep C, and finally care and treatment. And I'm going to do my best to kind of hit on those and inject and put a little bit of data that's coming out along the way so we can see what the blueprint is in Canada, how it's going so far, and then I'm going to do some comparisons with the US elimination strategy. So priority populations, as I was going through these blueprints for the first time, I was really thought it was very, very impactful that priority populations are really weaved through this document in a very high yield and very important way. And I think it's been said earlier today that we'll never eliminate hepatitis C in any country if we're not thinking about priority populations and understanding specific issues regarding these folks. And there's a reason why, and the numbers do support it. Up to 66% of people who inject drugs have either a current or a past hepatitis C infection. When people have experience in the prison system, up to a quarter of these folks have a current or past hepatitis C infection. Of course, the baby boomer cohort, people born between 1945 and 1975. In the States, we call it 1965, and I'm like dangerously close in Canada to being a baby boomer, so that kind of worries me a little bit. So I was sort of sad when I read that, the difference in years. But of 75% of people who are diagnosed with hepatitis C are born between these years. And finally, we had some great talks already about immigrant populations and some important points made. 35% of people with hep C infections in Canada are among immigrants, and really important, another point that was made earlier today, thinking about where they're coming from and what the prevalence of hepatitis C in the countries that they're coming from are. So I really wanted to start off with people who inject drugs and people who use drugs, who is 85% of new infections. And the blueprint really focuses in on issues that are unique to reaching this population, getting them to access care, and getting them treated. And a few things that I thought were very impactful and very important is a call to decriminalize drug possession for personal use. Of course, scaling up harm reduction services. One thing I think is very, very innovative is involving people who inject drugs and use drugs in the design of delivery of services. So not just making up what we think is going to work, but actually involving the people who are part of this in design of this. moving hepatitis C care to lower threshold environments. And that's another theme that goes through this blueprint, is kind of getting away from a brick and mortar. You make an important appointment in a doctor's office and you show up and you wait for 9:15 and then they see you and then you get your treatment, but really meeting people where they're at for their care. And then, of course, comprehensive models. We already heard a little bit about bringing a friend to clinic in Prince Edward Island. That system really works, and there's something that is going to be important in elimination. Now, when I talk to people that are outside of the realm of public health and outside of hepatitis C, and I say, this is what I do, and they say, well, why are you treating people who use drugs? Those people are never going to take any of their medications. And I think that's probably a common thing when you talk to anybody that's sort of outside of this room. And this was some really great data that was published about 2 years ago, looking at folks who are what we would consider pretty high risk for a lot of different reasons. People who use opioids and cocaine, people with a lot of alcohol use, unstable housing. And I thought this was just a really unbelievable study where 87 patients had 1,150 scheduled appointments, and 1,135 of these appointments were met, and about a 98 to 99% adherence rates to appointments. So certainly people who are using drugs are going to show up to clinic, and these are really great candidates to be able to treat their hep C. Thinking about other priority populations, 30% of people that are in prison either have had hepatitis C or currently have hepatitis C. And this really requires some specific thought about how to reach these populations and thinking about the risk factors that they have when they're entering prison. So what are the risk factors of these folks when they get into prison? What are the risk factors that they have while they're in prison? And then other stigma and other kinds of barriers that occur while they're in prison, such as lack of confidentiality, the stigma attached to it. And what do you do when somebody's already on therapy and then they have to go to jail right in the middle of therapy? Is that just going to be a lost cause, or are we going to have ways to continue their therapy and at least complete their therapy while they're in prison? Monitoring progress, it is a call. I think I'm probably the 10th person up here to talk about the importance of data and the importance of monitoring progress in Canada. We're never going to know if we're eliminating anything if we don't know where we started, if we don't know where we're going, and if we don't have a good understanding of incidence and prevalence and complications of hep C. And one of the recommendations in the blueprint is to have systematic biannual serosurveys with representation of priority populations, and then having ways to link this data to a usable format. And how are we going to use this data? One data set that I think is really leading the way is the British Columbia Hepatitis Testers Cohort, which is using surveillance data and administrative data sets, and they're linking these two things together to form a database. There's a lot of these coming up around in this country and in a lot of other countries. And you can use this data for lots of different applications, like following disease trends, monitoring progress of each program, looking for syndemics, and seeing what kind of intervention effect you're going to have, so the effects that you're going to have on certain interventions that you're going to do. So that's really important. Moving on to prevention of hepatitis C, 2030 targets call for a decrease of the incidence by 80%, 750 sterile needles and syringes per person who injects drugs per year, and greater than 40 people per 100 involved in opioid agonist therapy who are currently injecting drugs. So these are the targets for Canada. And I think it was mentioned couple of talks ago that these are actually even more lofty goals than is put out by the WHO. The WHO actually recommends 300 needle syringe sets per person who injects drugs per year, and only 40 per 100 people on opioid agonist therapy per 100 people who inject drug. And you can see here, let's see, that overall Canada is doing quite well, and I think this is putting Canada on a really good pathway towards elimination. You can see countrywide it's 66 people per 100 who are on opioid agonist therapy, and 291 syringe exchange, so you're close there. But what I wanted to make the point of is, even though the national numbers are very good, you're seeing a lot of heterogeneity amongst different provinces and different parts of the country. So some places are higher than others. And I think that efforts are being made, and we've already heard about a few, to kind of normalize this and get everybody sort of on the same page with this. So I think that these numbers are coming up, but overall, these goals are actually close to right now in 2020 surpassing some of the WHO recommendations. So some of the key targets for hepatitis C prevention that are outlined in this blueprint, certainly a hepatitis C vaccine. I think if we had that, that would really change the game as far as where we are going. I've already mentioned needle exchange and opioid agonist therapy, discouraging behaviors that will transition to injecting, peer-based interventions, and preventing reinfections. These are all things that are going to be really key, and the blueprint sort of outlines each one of these as far as how we're going to target these populations in order to prevent hepatitis C. Moving on to diagnosis and testing, it is estimated about 250,000 people in Canada are living with hep C, but 110,000 are unaware of their diagnosis, only about 44%. As we already mentioned, the 2030 targets are about 90% of people with hep C being diagnosed and confirmed with the infection. And of those, 100% of people who have a positive antibody or have antibody testing are going to have confirmatory RNA testing. So that's a really important point and something I think that we're close to being able to do. So how do you do this effectively? How do you get all these people tested? How do you reach these really high goals that are approaching 100%? The first thing is certainly one-time testing of everybody born between 1945 and 1965, and really thinking closely about testing for priority populations and people that have ongoing risk. And a couple of things I think the blueprint comes up with that spells out that I think are very important is really thinking about hep C testing and diagnosis, again, outside of traditional means of doing this. So improving access to screening, non-clinic-based screening, again, this concept of meeting people where they are and screening them not just in a doctor's office. Non-blood draw testing, I mean, if you're able to do it in a simpler way, why not? Reflex testing, again, if you're going to get to 100% of people that have been tested for hep C that have RNA testing, you're going to have to do it with reflex testing. Of course, thinking about people who are at risk, who are under 18 years of age, task sharing and online testing. And while looking through the blueprint, I stumbled upon getcheckedonline.com, which I thought is a really great resource. And I think a few of these are popping up. And this is a resource that is in British Columbia that you can do everything online. So you can register online. They can send you a kit. You can get tested. This is hep C, but other STIs. And it really makes it very accessible. It maintains anonymity of people that they can do the majority of this online. They don't have to walk in and be seen. They can do this kind of from the comfort of their own home. Again, just an example of thinking a little bit outside the box of how are you going to reach populations as they're getting harder to reach and may have specific needs. So treatment in Canada is well on its way, I think, to achieving some of the goals that are set out by the blueprints. Everybody knows that in 2015, DAAs were introduced. In 2017, there was a negotiation of lower drug prices for DAAs, which was really important. 2018, removal of fibrosis restrictions, which is way better than we're doing in the US, so I'll talk about that. Treat all recommendations, and finally, the elimination blueprint in 2019. And really, the 2030 targets, again, are to reduce overall mortality with a 90% linkage to a hep C provider, 80% of people who have hep C getting treated with DAAs, 95% completion with an 85% documentation of SVR, and reducing hep C prevalence by 90% and reducing mortality related to hep C by 65%. Okay, so what are some of the barriers to treatment? Some of the things is just hard to get treatment still, even though the medications are very easy, and even though it's probably easier to treat somebody's hep C than most other diseases that most providers take care of. There's still some unnecessary barriers, and the blueprint really deals with a lot of these, such as simplifying referral pathways. We already heard in Prince Edward Island that you can self-refer. This is really, really important to get people in. You don't need to see a doctor to see another doctor, which seems sort of cumbersome. eliminating things like pre-treatment genotype, eliminating viral loads. You don't need 1 million viral loads before you get treated. You just need one, and then you can be treated. No specialty restrictions, getting rid of a lot of these extra appointments. And post-treatment, thinking about what's the appropriate follow-up care for people, thinking about reinfection, counseling people about reinfection, and of course, folks that have cirrhosis, making sure that they're getting the proper surveillance for things like hepatocellular cancer. Building capacity is a theme that you're seeing in the Canadian blueprint and also the US elimination strategy. ECHO is probably one of the best examples of this, and there's a very strong ECHO program I know in Ontario. They do lots of different diseases, but certainly hepatitis C is one of them. I think anybody that thinks that we're going to cure hepatitis C and eliminate hep C by all these people walking into gastroenterologists and hepatologists and ID doctors' offices is wrong. This is going to be shifted into primary care setting, and I think most people are very aware of that. Thinking about utilizing technology, leveraging different forms of technology to get people treating is going to be really important. So ECHO is one of those concepts. The graph on the bottom is looking at direct telemedicine, so managing patients directly through telemedicine. You can see on the top line data, they have very, very high SVR rates, whether they're in person or using telemedicine. We're very fortunate with hep C that it's an easy thing to treat, and there's lots of different ways to do it. So it just takes knowing your patient population and having some creativity about how we're going to treat them, and we can get a lot of people cured. Okay, so this is data from the CDA Foundation, and I think that some people are going to agree with it more than others. So in no way am I saying that this is the Bible for the numbers, but I think this gives us at least one way of looking at it. So I'm just going to make a little disclaimer there. But there's about 200, and they also have really good graphics, and they have good pictures for slides and things like that. So about 212,000 people in Canada. This estimate's about 75% diagnosed. I think that's a little higher than some of the papers that have been recently published. 4% annual treatment rate, and again, about 1,500 deaths per day is sort of what was most recently posted. And this, again, looking at a lot of different data sources going into that, although it's not, I won't say that it is completely complete. You heard a much better talk from Dr. Barrett about Prince Edward Island, so she went into a lot more detail about that. But I wanted to put this slide in here to show how important microelimination is, and this is really the key to moving forward. And I think if you want to know what are the updates and what is new since the blueprint has come out, it's things like this, where Prince Edward Island is using, developing systems that are keeping the blueprint in mind and developing ways that make sense for that part of the country to eliminate within that population. Here using centralized triage, hepatitis C treatment specialists that aren't necessarily specialty providers, certainly no restrictions, fibrosis restrictions, patient education. I really loved hearing the lecture earlier that you guys are finding people that have missed 2 appointments and then going to their house. I mean, this is the kind of thing that sometimes is going to need to be happening in order to eliminate hep C. And of course, keeping a treatment registry. And you can see here the publication of about a 98% SVR people, the people they're reaching. And looking at it, this has also been in the news that in 2025, it's projected that hepatitis C will be eliminated in Prince Edward Island. So this is just a great example. There's lots of other examples of really knowing that area and having a plan going forward for elimination. So progress towards elimination, again, this is from CDA Foundation, but it's looking pretty good. And I know Jordan posted some data, some very sad data from about a year ago when Canada was stuck on the bottom with the US, although they were above it, but I asked, and it was alphabetical order is how that works. So I did ask about that. But we were stuck on the bottom, and I think there has been a lot of progress, at least over the last couple of months. Maybe this is from getting data a little bit better, but I think things are moving along. And in this graph, green is good. You can see reaching that 90% diagnosis rate and the 80% treatment rate, mortality targets, and the 90% incidence rates are all set to happen around 2030 or above. I think it's a really important point when you see something like this, and somebody earlier today made this. This doesn't mean like, okay, we're good to go, we can just stop here. This is really a call for ongoing commitment towards elimination. It says that it's possible, we can do it, but we have to keep moving forward. So I'm going to switch gears to the U.S. elimination strategy. So this was put out by the National Academy of Medicine in 2016 and 2017. It was sponsored by a lot of different groups, the CDC, Health and Human Services, National Viral Hepatitis Roundtable, IDSA, and the ASLD. And this was actually an elimination strategy for hepatitis B and C, but I'm just going to focus on hepatitis C here. There was two reports. The first report really tried to answer the question, is it possible to eliminate hepatitis B and C from the US by 2030? And the answer was yes, but there's going to be some serious barriers, and this is going to require a lot of attention. And what exactly is the strategy to eliminate it? This was organized in a few sections. This was the second report, looking at targets, essential interventions, delivering service, financing, and research. All right, so the targets in the United States also are a 65% reduction in mortality by 2030, and this will result in a 90% reduction in incidence, averting about 28,000 deaths by 2030 if everything goes according to plan. So to make these diagnoses, we're talking bigger numbers in the United States, about 110,000 diagnoses per year by 2020, by this year, 89,000 diagnoses per year by 2025, and 70,000 diagnoses per year by 2030. Now, even though that number goes down, these are hard targets to reach because as anyone that treats people with Hep C knows, when DAAs come out, everybody that has an internet connection and a day job shows up in your office, but it's the people that don't have those things that are harder to find and harder to treat. So even though those numbers go down, I would venture to say that the 70,000 diagnoses per year is way harder to do as we move towards this than the 110,000 that we hope to diagnose this year. In a big picture, in a 50,000-foot view, in order to do this, we're certainly going to have to treat without any restrictions. That's still something that hasn't happened yet in the U.S. And a consistent ability to treat new cases, even as we're finding cases and finding harder to reach population as prevalence decreases. So the first thing that the U.S. blueprint recommends, the U.S. elimination strategy recommends, is a central coordinating office. Health and Human Services, before the National Academy of Medicine blueprint came out, had an elimination plan. And this elimination plan involved 23 different agencies and 4 different departments. And that is just something that, even though it was very ambitious, I just don't know how that will ever be coordinated. It's obviously a very, very complex thing to eliminate any disease, and how are you actually going to do that? So the elimination strategy calls for the highest level of federal government to oversee a coordinated effort to manage viral hepatitis elimination. So again, this this elimination strategy came out in 2016 and 2017. That has not happened. Okay. For a lot of reasons, and we haven't gotten that yet. So something that we need, and something that is either going to be a new office or an expansion of a previously existing office. Thinking about hepatitis C transmission and essential interventions, similar to in Canada, we're seeing lots of acute hepatitis C in young opioid users. In the United States, this is some data from the CDC here, and you can see high rates of acute hep C in people under 30, and especially we're seeing this in rural areas. So the lighter blue bars are rural areas compared to urban areas. So we see it in urban areas, but we're really seeing a lot of injection drug use and opioid use and hep C in these rural areas. The plan calls for increased amounts of syringe exchange and opioid agonist therapy, but it really kind of hones in on making sure they're identifying gaps within our country. There's places in the United States where there's no access to syringe exchange and no access to opioid agonist therapy. So really filling in those gaps and making sure those options are there for people. So not only is it going to be enhanced viral hepatitis screening, but having states and federal agencies expand access to this with the places that are needing it the most. Scott County has come back in the news in the U.S. For a couple different reasons with the coronavirus outbreak and thinking about public health. And Mike Pence, who was the governor of Indiana at the time, at the time in Scott County, there was an outbreak in 2014 and 2015 of HIV. And again, I just heard this on the news when I was going to the airport, believe it or not. And what people don't know is about 92% of those folks that have HIV are also co-infected with hepatitis C. Just a plug that hepatitis C never makes it onto the news like HIV does, but it is true. The vast majority of those folks are co-infected. And even though this is a horrible thing that they had this outbreak within this small town in Indiana, it really shows how interventions that are directed towards the people that need them are highly effective. So once this was declared a public health emergency and the CDC came in and the federal government came in and services were being offered to these people, you can see that the new cases of HIV and consequently in hepatitis C went straight down. Okay, so these interventions, you can put these interventions in places that even have the least amount of access to healthcare, and you're going to see a very positive effect. So this was, even though it was a very horrible thing that happened there, this was actually in some ways a success story of public health intervention coming in and actually providing services to people that need them. So fibrosis restrictions and sobriety restrictions have been a big barrier to care in the United States. The graph of the United States on the bottom here is from a website called stateofhepc.org. And this actually, it's kind of a fun website to go to if you're not familiar with it. It gives every state in the United States a report card of how their Medicaid programs handle hepatitis C. Okay, so it goes from, I think, a D minus, maybe you can get an F, I'm not sure, D minus to an A. And what it's rating them on is what is the fibrosis restriction in that state, what is the sobriety restriction, and do you need a specialist to provide hepatitis C care? So it kind of rates them based on where the Medicaid programs are. This is a very, very new version. The lighter the red color, the better the state is, the closer they are to an A. So it used to be a very, very dark red map, and now it's a little bit of a lighter red map. But I just wanted to show it to you guys because it shows there is a lot of heterogeneity as far as access to care. There's places in the United States, if you're a Medicaid patient, that you have essentially unrestricted access to hepatitis C medications. And there's also places where you still have to have cirrhosis in order to get treated. So this is a big, big barrier. And of course, we'll never even come close to eliminating hep C if we don't eliminate some of these barriers for treatment. So the elimination strategy calls for, of course, getting rid of all fibrosis restrictions. So I live in Chicago, and Illinois Medicaid was one of the worst offenders. I'm not putting up this slide. Don't try to read it. I'm not putting up for anyone to read it, but I'm putting it up just to see how many words there are on it, because this was actually our prior authorization for DAAs in Illinois. And there's a lot of words and a lot of numbers there, and that means nobody was getting treated. It was very frustrating for me on the south side of Chicago trying to treat a lot of people that have hep C. The most frustrating thing, though, I just always have to bring this up, is number 2, which says patients must have a diagnosis of chronic hepatitis C genotype 1, 2, 3, or 4. Forgetting about the other genotypes, just that's it. And you have to have an RNA level, fine, I'll give you that, plus a Medivir score greater than equal to 4. So you have to be either cirrhotic or like super cirrhotic in order to get this, which, and it's like, it's sort of funny, but for us that we're treating patients in Chicago and in Illinois, I mean, it's a real punch in the gut because, clearly the person writing this policy does not have any understanding of physiology of hepatitis C, and here's what we have to go by. But like a lot of things, they end in legal action. So there was actually a class action lawsuit in Illinois just a couple of months ago that sued the state, got some patients on board to sue the state Medicaid program. And before it even went to trial, as has happened in a lot of states in the United States, the fibrosis restrictions got lifted and we don't have any sobriety restrictions anymore either. So it can come to an end. You hate to have to bring it to the lawyers, but that's what we had to do. But it worked, and now it's a lot easier to treat people with hep C in Chicago. I can't, you have to talk about building capacity in both Blueprint and the elimination strategy. ECHO is something that is actually mentioned specifically in the elimination strategy. Our models estimate that in order to reach elimination targets, we're going to have to treat about 260,000 people per year. That's a lot of people. And again, same thing as here, that's people that are not going to be going to GI doctors or ID specialists, things like that. This has to be done in primary care. There's just no other way around it. So there is a recommendation that the ASLD and the IDSA partner with organizations to shift a lot of this care into primary care settings, like things like ECHO. I'm involved in ECHO and hepatitis C for the last 5 or 6 years. And I can tell you we've trained almost a little bit over now 350 providers within within Chicago that are just treating Hep C. We have a huge Hep C population in Chicago, and we're training these people. And you can see it's not all physicians. These are a lot of nurse practitioner, nurses, pharmacists. Everybody's kind of getting in on this. And here's a map of Chicago. So just to orient, in case anybody, this is Lake Michigan over here. I'm not sure. I don't know where that guy is. It must be like an island in the middle of Lake Michigan. But this is Chicago, and this is how we've done over the years. We've really tried to focus on federally qualified health centers where people have very, very limited access to care. And you can see the dots are getting more and more because we're expanding. So we're actually, in a very nice way, we've sort of extinguished all the providers that want to learn how to train. We're hoping we've sort of trained them all by now, and now we're expanding out through the rest of the state and into Southern Illinois. And then finally, you really have to talk about comprehensive models, and the hepatitis C elimination strategy from the National Academy of Medicine spends a lot of time on this. And I like to use this graph that I found that really shows, I think it's important because it has all the information, but it kind of puts hepatitis C diagnosis and treatment kind of on the bottom here. And it really shows sort of graphically how important everything else is when you're thinking about comprehensive models of care. So harm reduction, care, support services are all right in the middle. That includes peer support, that includes opioid substitution therapies, of course, syringe and needle exchange, psychological care, HIV testing, making sure everyone's getting screened. And if they are positive for Hep C, screening them and curing their hepatitis C as well. But really thinking about this as a multidisciplinary model, not just doling out a bunch of DAAs to people, because we know that that's not going to really get us to where we need to be. And of course, there's a recommendation and the strategy to set these things up on more of a wide scale. We have something called Ryan White, which is sort of this type of program for people with HIV. And if we had something like this for hepatitis C in the United States, it would be really great. And then finally, paying for it. So understanding finances of drug costs and insurance in the United States is extremely complicated and very opaque. And the costs we know of DAAs are the reasons what are driving a lot of the fibrosis restrictions that we're seeing and sobriety restrictions. The strategy calls for just thinking about different ways of financing above and beyond sort of what we're doing already, because the cost is still too high for where we're at. The Netflix model is something that's actually becoming more and more popular in the United States, and more states are using this. So who's familiar with the Netflix model? Anybody? Okay, so Netflix, everyone's familiar with Netflix, right? So Netflix, you pay your $10 a month, and you can stream all the movies you watch. You can binge watch everything all day long, and it's great, right? So this is the same idea, but with hepatitis C drugs. So Louisiana is doing this, Washington State is doing this, and what they're doing is they're paying a pharmaceutical company a lump sum of money to cover all the hepatitis C drugs for a given amount of years, so say for 5 years. And then everyone they treat, it's on that drug company. So they get the money up front, and then everything is free. Same idea as if you pay your $10 a month, then you get all the movies you want. And the critiques of this at the beginning is like, no drug company is going to go for this because they're going to want to charge by patient. But the way that the finances work out, getting a huge chunk of money up front for the next 5 years is very, very attractive to them. And the states that have done this actually have had competitive bidding for each of the states from all the drug manufacturers, that they all wanted to do this. And it's really great because, number one, it lowers the cost. It's great for states because they can budget. They don't have to worry about, we don't know how many patients we're going to treat. And it's great for patients because it incentivizes states to treat, because, hey, it's on the house. Let's try to get as many people in the door as we actually can. So this is a model that, it doesn't work for everywhere, but it works for a lot of places. And this is something that's a great example of sort of innovative ways of thinking about treatment and how to pay for treatment. U.S. has a less rosy picture as far as reaching elimination goals. So about 3 million people in the U.S. With Hep C. We have a lower number of people diagnosed, about 63%. Low numbers of treatment, about 8%, and we have 3 deaths per hour in the US from hepatitis C. Microelimination, just like in Canada, is going to be key. This is leading the way. Programs like End Hepatitis C SF, which you can see is a very, very multidisciplinary care model using a lot of different ways to reach patients is very, very successful. Philadelphia Fight is a program in Philadelphia that is aimed to eliminate hepatitis C in that area. And of course, places like New York State have eliminations task force. This is by no means an exhaustive list, but there are certainly these micro-elimination projects that are popping up all over the place and are very effective and things that we need to start seeing more of. When you look at our elimination targets, we're good on a few as far as diagnosis and treatment, but reducing incidence, we still have a long way to go for hepatitis C. And part of this is because of our barriers to treatment. So still quite a long way to go. So I thought to conclude, I would sort of do a comparison and contrasting of what's the same and what's the difference between the Canadian blueprint and the United States elimination strategy. I do think that the blueprints really does a great job of thinking a lot of being very, very thoughtful about priority populations and identifying these populations and coming up with access to care and treatment models that are very pertinent for these populations. It also calls for needs for centralized database, certainly hepatitis C prevention with opioid agonist therapy and syringe exchange, reducing barriers to testing and treatment, building capacity, and then diagnosis and treatment in children. And I'm sorry to any of the pediatricians here that I didn't spend as much time as I should have on hepatitis C in children, but this is something that comes up a lot in the blueprints and is really, really important to address. US plan really focuses on a few different things. Number one is creating a centralized office because there's such huge numbers of patients and huge amount of screening and database work that needs to be done and needs to be sort of centralized in one place. And this goes with improving surveillance, making sure we have databases that can give us the types of information that we need. Same ideas with preventions and barriers to testing. In the US, we really need to do a lot of work with improving DAA access. There's still pockets of our country where you need to be cirrhotic in order to be treated. Continuing work with capacity building and still finding ways that are creative to finance these patients to get drugs. So the take-home points, I do think elimination goals are achievable. As of right now, Canada is doing very well, and I think there's a lot of signs that they're on a great path towards elimination. I think we have a lot of serious barriers in the United States that we still need to overcome. I do want to focus on micro-elimination. I think this is going to be an important model to show and prove that hepatitis can be eliminated in certain parts and figure out what works and what doesn't work as we expand those micro-elimination projects. Really thinking carefully about key populations, reducing barriers to treatment, and also finally thinking of comprehensive plans that work in whatever region of patients that you're treating. So with that, I'd like to thank everybody for your attention and open it up to questions. Can I open it up to questions? No? Yes? Sure. Thank you.